Right, all right then. So I think we might make a start. Good evening, and everyone, and welcome. We're all very thrilled to have such a strong turnout for tonight's session. And as I said, we hope you've all got your cup of tea or something stronger and ready as we settle in for a real informative evening. So before we begin tonight's webinar, there's a couple of things I'd like to just acknowledge. First of all, of course, I'd like to acknowledge the traditional custodians of the land on which we're all meeting here today. I'm speaking from Melbourne, the land of Wurundjeri people, the Kulin Nation, and I'm sure you're all speaking from all different parts. I pay respect to elders, past, present, and extend that respect to all Aboriginal and Torres Strait Islanders people joining us this evening. Now, I also would like to acknowledge the very generous sponsorship of GC, who is kindly sponsored the event, the webinar this evening. GC is a company, for those who may not be familiar, that supplies a lot of products that we use for prevention of decay and caries in the xerostomia patients and cancer patients, and in the general dental population as well. I certainly have one of their products that I use myself, tooth mousse. So we're all very privileged, I think, that this evening we've got an outstanding panel of experts that all play vital roles in the multidisciplinary care of the head and neck patients, from early in the post-treatment phase right to the end, and even beyond the surveillance and the survivorship. So I'm going to make some introductions of all the panelists and the speakers this evening, and it will be in the order as how they'll be presenting. And we will be formatting this way this evening that there'll be 6 presentations by these lecturers and presenters, followed by a panel discussion that I'd really encourage all the attendees to write into the Q&A box or in the chat. That will certainly be able to actually direct those questions, and especially clinically orientated questions, to any of these members of the panelists as well. So we're going to start off with Dr. Emma Charters. Dr. Emma Charters is the lead speech pathologist team at Chris O'Brien Lifehouse, and she's developed an integrated clinical and research program focused on swallowing, communication, rehabilitation, and co-developed a novel 3D printed device for trismus management, which is what we'll be hearing about tonight. And the next speaker is Dr. Howard Liu, who is a radiation oncologist at Princess Alexandra Hospital and Icon Cancer Center. And he's got a special interest in head and neck cancer and stereotactic radiotherapy, and is actively involved in clinical and translational research. Next after Dr. Liu is Associate Professor Su Ching Yeo. And Sue is an oral medicine specialist in Sydney with a dual role in private and hospital-based practice. She's the current president of the Oral Medicine Academy of Australasia and chair of the ADA Therapeutics Committee as well, with expertise in oral mucosal disease, complications in medically complex patients. Next, we have Associate Professor Matthew Lim, who is a special needs dentist and director of the dental services at the Alfred. He also holds senior roles at one of the hospitals where I work, at Royal Melbourne Hospital and St Vincent's Hospital, and is a current president of the ANZ Academy of Special Needs Dentistry. His work focuses on improving the care of patients with complex medical needs, and has been a very strong advocate of the inclusion of dental care in the care of not only head and neck cancer patients, but the patients that need, like the special needs patients as well. And then we have Dr. Ken Thistlethwaite. Welcome, Ken, like I said, who's a specialist hyperbaric medicine and former co-director of the service at Royal Brisbane and Women's Hospital. And with a background in general practice, anesthesia, and diving medicine, he's a leading educator and advocate for HBO therapy and complex wound and ORN care. And finally, we have Professor Martin Badston, who's the director of the maxillofacial surgery unit at the Royal Brisbane and Women's Hospital and the clinical lead at the Hurston Biofabrication Institute. And he is a past president of the ANZ Head and Neck Cancer Society and a strong leader in the head and neck oncologic surgery and microvascular reconstruction field. So thank you very much to all the speakers for joining us and sharing your expertise tonight. We're going to start things along because we do have a lot to pack in. So Dr. Emma Charters, over to you if you can share your screen and start. Thank you.
Hi there, everybody. So as I was introduced, my name's Emma Charters. I'm a speech pathologist at Chris O'Brien Lifehouse, and it's a real honour to be here tonight. So thank you for having me, and I'm calling in from Gadigal land. So while this is unlikely to be truly jaw-dropping, I do hope that some of this provides a little bit of food for thought. So before I begin, I just would like to take the opportunity to declare that I'm a co-inventor of Restorabite, which is one of the trismus devices that I'll mention a little bit later on, together with my colleagues, Professor Jonathan Clark and Kai Cheng, a head and neck surgeon and an engineer, who together we hold the patent for the device. So while speech pathologists treat a whole number of different conditions related to head and neck cancer diagnoses and treatment, I thought the most relevant to an oral complication webinar with a spotlight on dental care would be to discuss trismus. But I first wanted to acknowledge that the information that I'm presenting you here is work done through a powerhouse team of clinicians, scientists, and researchers. And here's some of their friendly faces. So trismus, I'm sure you're all familiar with 35 millimeters, which is, below that we tend to say that's a classification of trismus, and all three stacked fingers between the upper and lower dentition. Usually, if they've got missing dentition either on the top or the bottom, we would sort of consider that around 10 millimeters, and so anything sort of gum to gum, 55 millimeters or lower, would also classify as trismus. However, I think while that measurement is really helpful and it's been validated on patient-reported outcome measures, I think getting our assessment right and really understanding what trismus is really important before we think about the management and treatment of it. And so often asking patients, do you feel like you've got a restriction in your mouth opening? Do you feel like there's been a change? Asking whether they've got any functional limitations that they've had a problem with, because as you can see on the normal mouth opening side, and a mouth opening, I'm going to talk about it a little bit later on, a mouth opening of sort of 45 to 60 plus millimeters can be normal. And so you wouldn't want somebody to sort of drop 20 millimeters before we let them have trismus treatment or something like that. So I think having a thorough assessment and knowing exactly some of the indicators of what might indicate trismus, whether that is a drop in mouth opening or whether they do sort of meet that 35 millimeters meter mark is good to sort of think through. As you all know and can see here, we're talking about when we're talking about trismus, we're talking about a significant restriction in mouth opening, meaning that they struggle to eat, talk, and get good dental care. And it has a significant impact on their lives. So one of our patients described it like this: you can't really enunciate your words and people can't understand you, constantly mumbling away. It's frustrating for me and my audience. And then you have the minor challenge of getting food in your mouth. It's a big problem. So the challenges are expanded upon here. And so you can see the pathway that trismus takes if it's untreated or in a refractory type of case. We see challenges in patients carrying out oral care, particularly important, which is particularly important in, after having had a neck cancer treatment. It limits the textures and the volume of food that's able to be consumed, and the speech makes speech a lot more difficult. It impairs oral examinations, cancer surveillance, visits, and dental restoration, and that leads to problems like anxiety, social isolation, and malnutrition. It also, when thinking about dental procedures and things like that, trying to fit a palatal prosthesis for somebody with a palatal defect, or then other types of dental restoration is very difficult when you have trismus. So unfortunately, this is in a small number of patients. We know that the incidence of oral cancer and head and neck cancers generally are increasing worldwide, particularly in a younger demographic of patients. Also, we know that there's a whole bunch of different risk factors that lead into patients who we know are more likely to get trismus, depending on the multimodality types of treatment, often surgery plus radiation. We know when we're looking at different dose contours and the locations of and sort of anatomy that's involved. But we also know that if they've had a TMJ disorder prior to their head and neck cancer treatment, that they've got a higher risk of developing trismus. And now when we're looking at our risk profiles, we often are asking patients more often about whether they've had TMJ function or different difficulties beforehand, because I think we need to be more conscious of those guys. So as I said before, I think really understanding a good way of assessing patients is really important, because if we know the assessment well, we can help to manage them a lot better. And there are a lot of different ways that you can assess trismus, as I'm sure you're aware. So you can use fingers. That's really helpful, like, 3 fingers between the top and bottom mouth. But when you're sort of measuring change over time, a finger isn't often a particularly specific, which is when we move to rulers and other ways. And so Orostretch and Therabite are the main 2 big players in terms of mouth opening measures. You can see the different options there. There's calipers that are used. There's paddle, how many paddle pop sticks you can fit between your teeth, a whole bunch of different ways to do it. But I think the main thing that you've got to think about is if you're going to measure somebody over time, whatever one of those you want to use, fabulous, but use the same one each time so it's replicable. So you want to use the same method in the same place. So in our notes, we document where the measurement was made from, and then use a tool that the patient can replicate. Because if you're sending them home and you're going to tell them to do some exercises but call you if you've got a problem, they need to be able to measure it in the same way that you're measuring it. So choose something that's simple and easy and, as I said, can be replicated by the patient so that they can start sort of taking that active management themselves. Because often when you are going to have a person with trismus for the rest of their life, they might be moderating what their maintenance exercises look like, and they need to know what their mouth is doing to know whether they need to increase their exercises, decrease their exercises, or call you because their exercises are no longer working anymore. So those are also the clinician rated measures. There's a whole bunch of different interesting things in VR that's happening as well. But those are the main ones that we use more often. And then patient reported outcome measures, and they're obviously critical to ask. First of all, there's that just question, are you having problems? Yes or no? That's a really nice question to start with. And then there's the mandibular function questionnaire, mandibular function impairment questionnaire that you can use. Also, and the Guthenberg Trismus questionnaire, the two major patient reported outcome measures that we have usually. Quite helpful to think about the severity of trismus as well. So if we can, again, looking at that range of normal. So if we're seeing if we waited for somebody who was sort of 55 millimeters to get to the magical 35 number before we offered treatment, then that would be a problem. I think we probably also are underreporting trismus because by the time we measure it in that sort of post-treatment phase, they might be at a 36, but so they might not have trismus, in that classification, but they might have used to be 60. So I think we've sort of started taking that pre-operative or pre-radiation measurement a little bit more proactively now, just to understand what that patient used to be like. It also helps to set our goal setting when patients are going back to back to their lives afterwards, and just knowing what's normal for them helps us to sort of direct patients to get them back to where they used to be and where they're hoping to be. I think the other helpful thing is to think about a clinically meaningful change, and often it's 5 millimeters in the literature. So if somebody makes an improvement or a decrease of 5 millimeters, that's been classified as clinically significant. So thinking through that as well if patients are moving and changing over time. Now, I'm sure that a bunch of these are familiar to you, but these are all of our devices generally that is available at the moment. So we've got the OraStretch and the TheraBite are both ones which operate reasonably similarly. If you haven't used them before, they're operated by, you squeeze the handle end, and then the mouthpiece end opens up. And so the person moderates the amount of pressure based on how hard they squeeze. Stacked paddle pop sticks have been around forever, as many as you can shove in between your teeth. You can do it sort of directly in or sideways. The one at the top is called a jaw clamp. It was designed by somebody in Canada who had head and neck cancer treatment and didn't like the options. You can also do manual therapy. There's a lot of work in lymphedema. There's a lot of work in laser, and that manipulation and the massage is really important. There's also a program called the ARC-J, which is a different way that you can arrange paddle pop sticks that provide a little bit of a spring motion to them. We did a systematic review on this a couple of years ago and found that these devices in the rehab setting all had a significant improvement in mouth opening of around, I think it was around 6 to 8 millimeters across the meta-analysis. We didn't see the same in the preventative setting, but that came down a lot to adherence, and that's a real challenge when you're going through radiotherapy. We've also done a survey of all of the clinicians, well, not all of them, we've invited all of them to tell us what they were doing in terms of trismus management across Australia, and sort of looking at the barriers and facilitators of providing management for trismus. And there's a lot of barriers, and it comes down to a bunch of different things. There's the normal ones like difficulty in time and space and resources, but there's also the lack of mentoring and training for people outside of their institution. So it means there's quite a lot of variation in terms of the trismus management that's been happening. Devices sometimes are too expensive, so they're using paddle pop sticks, and they're not really, and there was a bunch of people who weren't quite sure about the right exercise regime to use. Something else that came out quite a lot was a concern of, particularly from speech pathologists, that are going to cause harm when they're doing their trismus intervention. And that came down to quite often that force, you can't regulate force in this setting. So for the first quote, some people are really worried about their teeth, and so they do the lightest amount of pressure and they don't improve. And so we're looking at subtherapeutic if we're not using enough pressure. And then we've got the other end of the spectrum where they're worried that they're going to apply too much pressure, particularly in the last quote, it's that particularly people who've had segmental mandibulectomies, they're too worried about putting pressure through an early reconstruction without bone union. But then they start radiation, they miss the boat for doing rehabilitation. We also know that often when we're trying to provide a stopping limit for when, how much force is too much, we often say pain. As soon as it's hurting, let's stop at that point. But we also know that patients who've had head and neck cancer treatment don't detect pressure in the same way that we do. And so we did a study to have a look at how much pressure it took for somebody who'd had head and neck cancer treatment to detect that pressure versus somebody with a healthy control. And we know that there's a lower threshold, that patients don't pick up that pressure. And so we also know that detection of pain can be a little bit of a red herring and not always particularly helpful. So that's when we decided into the Restorabite, which you might have been familiar with. We wanted it to be have equitable access. We wanted it to be a bit cheaper. We needed it to be portable, and we needed to have regulated force levels. You can see it sort of working there on the side. These are the forces. So we know that if you've got the way that it works is you can move that little insert up and down, and so the closer to the mouth it gets, the more pressure you have, the lower it goes. If your mouth opening, it's sort of pressurized when it's closed. So the tighter your mouth is, the more significant your trismus is, the higher that pressure will be. And so we can work out from, depending on which position the insert is in and their mouth opening, we know exactly how much pressure they will be receiving. But there's a lot that we don't know. So we don't know what the ideal exercise regime is. Mostly they've been using 30 seconds by 5 by 5 or 7 by 7 by 7 as a regime that's in most instructions for use or in the literature. But we did a study a little while ago that says that's not necessarily true. And well, you know, it works, but it might not be the optimum for the patient. Adherence has always been a big problem, and it's hard to get patients to adhere to the exercises because they've got a bunch of different priorities, and that might change over time. And they've been told to do 1,000 things, and trying to fit jaw exercises are difficult. So what we tend to do is tell them to do the exercises before they do activities which require their mouth to be open. So they might do 2 minutes before they brush their teeth in the morning and night, and then 2 minutes before they eat each of their main meals or something like that. And definitely tell them to use it before they go and see a dentist. More recently, we've been looking at ways to minimize trismus post-segmental mandibulectomies, and using Restorabite, because we can moderate exactly how much pressure is going through there, we can sort of provide a little bit of a loose protocol where, rather than waiting sort of the longer few weeks after surgery when radiation's beginning to start their trismus exercises, we can guarantee that there's not going to be more pressure than that 10 newtons with the frame by itself. The surgeon tells us where they want to do it, and then we can start doing exercises a little bit earlier, because that preventative space is still something that we want to understand a little bit more about, and how we can optimize and personalize the exercises for patients. This is my delightful speech pathology team. Thank you so much for your time, and I'll look forward to some questions later on.
Thank you very much, Emma. Yes, just so that we can actually get through the content, I thought I'd just move on to the next speaker, Dr. Howard Liu. But please do, just as a reminder to everyone, could you, if there are questions so that you don't forget them, please put them in the Q&A box or in the chat box, and we will be reviewing them. Over to you, Howard. Thank you.
Good evening. Great talk, Emma. I'm just going to move on to some exciting developments in the head and neck radiotherapy management of patients that I'd like to take you through this evening. So we might get started with talking about what are patients reporting during their treatments and after radiotherapy. So this is probably the most comprehensive study that I've found and read about patients reporting toxicities associated with radiotherapy and the impact of quality of life. And the summary is most patients get quite a bit of oral issues from week 3 and 4 onwards of radiotherapy. A typical course is 6 to 7 weeks, but they do get recovery from week 12. In terms of ongoing problems, patients do report that they have a dry mouth and sticky saliva, and that seems to be still quite a bit of a problem for patients after radiotherapy. So I've just flagged here the main domains and toxicities that the patients report in terms of oral issues: dry mouth, problems with opening the mouth, pain issues, taste changes, sticky saliva, and trouble with social eating. So most of these issues do resolve, but dry mouth and sticky saliva persist. In terms of teeth issues at 12 months post-radiotherapy, there's still, over 40% of patients who do report at least mild problems with teeth issues, particularly in a group that have a primary site involving the oral cavity or oropharynx. Now, oral mucositis from radiotherapy is a very common problem. It typically starts from week 4, and the oral mucosa is sensitive to radiotherapy. So you get a dose of 39 gray and above and you would expect that the mucositis can stay for at least 3 weeks or longer. A typical course of radiotherapy in head and neck is at least 60 gray to 70 gray. So in a typical prescription for radiotherapy, the clinician is usually aiming to reduce the amount of volume of uninvolved oral cavity above 40 gray to be as low as possible. Now, just briefly touching on how radiotherapy is being planned in this era and how it's being delivered. Radiotherapy now is all volume-based prescription. So we need to define where the gross disease is. We need to define where the subclinical disease volume is, and we prescribe a radiotherapy dose there. We also need to define where the uninvolved organs are, what is an acceptable dose to those uninvolved organs in terms of a risk-benefit ratio compared to cancer control. The treatment is delivered in a modulated technique, which I'll go through shortly, and to improve accuracy, standard of care for radiotherapy is using image guidance for delivery. Now, in terms of volume-based prescription, we have much better access to modern imaging, medical imaging, to improve and identify the extent of gross disease, to identify the volume of gross disease. So with available PET imaging and structural imaging, we can better identify what is actually the volume of gross disease present compared to what may not be necessarily a big amount of big volume of gross disease. We can also better identify and separate gross disease from subclinical disease, which usually represents low volume microscopic disease. And we can better accurately identify where the uninvolved organs are. So gross disease, which is clinically and radiologically apparent, is typically dosed to 66 to 70 gray over a 6 to 7 week period. Where there is high volume microscopic disease, that's dosed to 60 to 63 gray. And when there's subclinical low volume microscopic disease, that's dosed to 50 gray. So in terms of utilization of advanced medical imaging, MRI access is increasingly available. In my public practice, we have a dedicated MR within the department that we use to plan patients for head and neck treatments. And you can see the utilization of and have the benefits of using advanced medical imaging. In this scenario here, this patient has a tongue-based cancer that we're treating definitively. We need to do a CT planning scan on the right there because we use the Hounsville units from CT to know where the radiotherapy is going. But it's very hard to define the extent of that gross disease and the volume of that gross disease. But with the advantage of MRI, we can be a lot more precise, accurate, and we can very much keep the volume of gross disease to the actual extent of that disease volume. So even without MRI, departments can utilize contrast enhancement to try and better define the extent of the disease, but MRI just takes it to another level. Now, in terms of how radiotherapy is delivered these days, it's through a modulated technique. What that means is the radiotherapy machine is moving constantly around the patient, delivering beamlets of radiotherapy focused on the volume defined as the gross disease. So on the image to the left side of the screen, this patient has a tongue-based primary with a large left neck node. The focus is delivering 70 gray to that volume using multiple beamlets delivered around the patient. When we're also looking at delivering dose to subclinical disease, this is the dose map where the radiotherapy is being shaped around the subclinical area, which is the elective neck, and focusing the heat depicted in the red area to the gross disease. Image guidance is also standard of care to ensure that patients receive accurate delivery of their radiotherapy. So most patients who have their head and neck radiotherapy, they get a daily CT scan to make sure they're in the right position. Newer machines also give an assessment of the scheduled dose delivered per day. So that gives the clinician a chance to re-optimize the patient's radiotherapy plan following tumor response and anatomical changes. So we can't expect that the patient's anatomy and tumor will stay the same throughout the 7 weeks. So this is a chance to re-optimize the plan and reduce dose to uninvolved organs. So this is an example of scheduled dose that has highlighted an increased dose because of anatomical changes. The image on the right is what was planned at day 0, where we're looking at increasing or delivering 70 Gray to the nodal disease in the right neck. But during treatment in week 4, the patient's anatomy is changed, the tumor is shrinking, and the dose delivered is starting to heat up. So the blue area here represents the 70 Gray and is extending out in the neck. So this is the opportune time to re-optimize the plan so that uninvolved structures don't get overdosed. Going back to clinical management, this trial was published last year looking at oral probiotics to manage severe oral mucositis. 160 patients randomized trial in patients receiving radiotherapy plus or minus chemo. And there was significant reduction in the incidence of severe oral mucositis with the use of this oral probiotic that contains Streptococcus salivarius. And during radiotherapy, the blue line here represents the intervention arm, red line being the placebo arm. So with the probiotic, it significantly reduced the incidence and score of oral mucositis throughout the entire course of radiotherapy. So that's what I've incorporated in my clinical practice. Xerostomia typically starts week 3 of radiotherapy. And you can see on the graph here, salivary flow does improve after 12 months, but patients still report that the dry mouth remains a problem in quite a bit of a problem following their radiotherapy. And the reason I suspect is this parotid and the submandibular gland, they're very radiosensitive. So this is a normal tissue complication probability. On the left here, 50% of patients, when they receive about 35 to 40 Gray, will expect salivary flow to drop to less than 25% at 1 year compared to baseline. And that's the same for submandibular gland. And this is long-term sequelae following radiotherapy. Because that's half the dose of what we typically prescribe for gross disease. But there are advancements made to optimize radiotherapy planning to reduce the effect on patients' reported outcomes. So this trial looked at optimizing dose to the pharyngeal constrictors. It improved swallow function, but as a secondary improvement, patients were reporting that their taste recovery was a lot faster at 12 and 24 months. My hypothesis is that patients probably have a lot less secretions when there's optimization of dose to the pharyngeal constrictors, leading to improvement in taste. There's also been advancements in how we dose subclinical disease with advanced medical imaging. I mentioned previously for low volume microscopic disease, the standard dose has been 50 gray. This trial published earlier this year compared less than 40 gray to 50 gray. The recurrence rates were small and the same, but tube feeding rate halved, and there was a lot faster dry mouth recovery and sticky saliva at 3 months. In terms of actually omitting the 1B submandibular nodal region, the Memorial Sloan Kettering group in their HPV-associated oropharyngeal cancers have been not including this nodal region if it's not involved. And what the patients reported following this treatment was that their scoring of dry mouth and sticky saliva reduced to a little problematic range, much rather than a moderate or severe problem after treatment. We're also being a lot more selective for patients having unilateral versus bilateral neck radiotherapy. And this local trial, dry mouth was significantly improved 2 years post-treatment, but global quality of life measures was the same. It does suggest that we can continue to improve how we deliver radiotherapy. What about osteoradionecrosis in a modern radiotherapy era? Well, it depends on how it's being graded. Clinical trials suggest that surgical intervention is required in about 2% of patients. The latest publication using this novel classification, ClinRad, suggests that is about 5 to 6%. But the risk factors remain. This is current or ex-smokers, poor periodontal conditions, if the primary sites involve oral cavity or oropharynx, if the radiotherapy prescription is 60 gray and above, and if patients have had bone resections. Now, in terms of radiotherapy-related risk factors, it all comes down to volume. How much of the volume of mandible is receiving 50 gray and above? These graphs here show the normal tissue complication probability, and the authors suggest that even the low dose of radiotherapy going to the mandible increases risk of osteoradionecrosis. A target of keeping this risk less than 5% is keeping a third of the mandible getting more than 35 gray. You want to lower it even more, you have to look out for low doses, including the 17 gray area. In terms of dental extractions, pre or post radiotherapy, we've got guidelines which suggest that if there's any teeth that is associated with poor prognosis and we're expecting bone dose to be 50 gray and above, they should be removed at least 2 weeks prior to radiotherapy. Any bone that's receiving 50 gray and above is at risk of osteoradionecrosis, but for rapid progression of tumor, we should try to defer the extractions given cancer control risk. Now, my thoughts on management of the teeth prior to radiotherapy, I can't stress enough the communication between the radonc team and the dental team is key. Presence at the MDT by the dental team is optimal so that we can streamline oral assessments. We can coordinate dental treatment plans with the timing of radiotherapy. We can discuss the planned radiotherapy volumes, anticipated dose to bone, salivary hyperfunction. And then we can discuss oral assessment findings so that during planning, we can look at efforts in minimizing dose when extractions are deferred. What about post-radiotherapy? If you find yourself in a situation where teeth may need to be extracted, well, we really need to look at the radiotherapy dose map prior to any dental treatment plan. As I said, anything above 50 gray, the bone, it's considered at risk of osteoradionecrosis. The direct communication is key. All right, I'll finish up there.
Thank you very much, Howard. That's really useful. And I think some new guidelines that's come out, that's very useful to share. So thank you for sharing that. Let's move on to Professor Su-Ching Yeo on the topics of the mucositis, expanding on from once you get those mucositis and how best to manage them. Thank you, Sue.
Thanks, everyone. I hope you can see my screen. Let me just... So Emma and Howard have given two very comprehensive presentations, and we've got a little bit of an overlap, so I'm hoping that we can whiz through a couple of these slides. As we're all aware, there's multiple ways in skinning a cat, multiple ways in which we manage head and neck cancer. And, you know, obviously lots of different variables, staging and site and prognosis and what have you. We've focused up till now on predominantly radiotherapy, but I just wanted to mention that there are oral effects of many of the other cancer treatment modalities as well, and we will probably touch on those as the evening goes on. This is a slide with a whole heap of words on it, and obviously we're not going to go through all of that, but I've put it in for completeness. The couple of things that I wanted to point out with this slide is that commonly we talk about the effects of radiotherapy on the mouth, and we tend to segregate these in terms of a timeline. So we talk about what happens in the acute phase, and this is sort of like, you know, from the time of treatment when it starts to a couple of weeks down the track. And then we talk about midterm or intermediate effects, which extends for, you know, roughly 4 months post-treatment. And then the late effects, and these can happen essentially at any time thereafter. Things that I'd like to highlight, as Howard has already mentioned, is the oral dryness, and we're going to talk a little bit about that today together. But you'll see that oral dryness or salivary dysfunction actually features in all three categories. So it actually occurs very early on in the piece, it persists in the intermediate phase, and then it can be one of these longer lasting problems that patients will often struggle with. If we talk about mucositis initially, so mucositis essentially, as you all know, is inflammation of the oral mucous membranes. It does start, you know, a couple of weeks from the start of therapy, and it does take about 4 weeks or so to heal after radiotherapy or chemotherapy is ceased. And the reason for that is that the oral epithelium actually takes about 4 weeks to regenerate. So it does linger for a while. We do know that the distribution of oral mucositis is slightly different depending on the modality of treatment that the patient is receiving. So radiotherapy, it's really only the mucosa that's within the field of radiation that develops this ulceration. With chemotherapy, it tends to affect the entire oral mucosa. Very commonly, patients present initially with erythema, and then it develops quite quickly actually into large areas of painful ulceration. And you can see by these photos that it looks horrendous. It actually looks really, really painful, and it is really, really painful. To the point where patients can really struggle with this. Apart from having difficulty, you know, eating and drinking, some patients actually need to disrupt their cancer treatment because of this. So this is a significant issue. Luckily for us, there are some very nice guidelines that are published, and many of you, I'm sure, will be familiar with this paper that talks about clinical practical guidelines that we can use to assist our patients. And I've just summarized some of the findings there, particularly in terms of using anti-inflammatory agents and such as benzylamine mouthwashes in the prevention of mucositis. Increasingly now we have options to use low-level light therapy or photobiomodulation to prevent mucositis in some cases. Sometimes we use ice chips or cryotherapy, particularly if patients are receiving bolus 5-FU chemotherapy. And then there are options for analgesics and other interventions there. Howard has very kindly already given us a very good introduction to the oral dryness or salivary gland hypofunction. And this is generally permanent damage to the salivary gland tissue within the radiation field. As Howard has mentioned, it does seem to be worsened obviously as the dose increases, but we do know that there is irreversible damage to the salivary tissues at doses of over 50 gray. And it's not just the quantity of saliva that's produced that is affected. So patients often don't have a lot of saliva, but the saliva that is produced is also of reduced quality. And I guess coming from a dental background, for me, that's actually very significant because saliva is actually very protective. We don't know what saliva does until we don't have it. And so saliva will actually protect the dentition, the teeth, and having less saliva or poor quality saliva will actually adversely impact that. And I think Matt is going to touch on that a little bit later this evening. Obviously, patients with dry mouth, they present with obviously the symptoms of dry mouth, and they say that, you know, my saliva is very sticky, or my tongue is sticking to the roof of my mouth. I seem to be thirsty all the time. I can't enunciate my words, as Emma mentioned before. You can't speak properly, you can't eat properly. Those patients that wear dentures have real trouble actually, you know, putting their dentures in and retaining their dentures in there, and they can be actually very, very uncomfortable to wear dentures and a mouth that is dry. Lots of patients come in and they say that my mouth is stinging all the time. I've got this burning sensation, and food just doesn't taste right. It tastes like cardboard. So there's associated taste disturbances. We do know in terms of the remaining dentition that a dry mouth can actually accelerate the caries process and also the periodontal disease process. And finally, we also know that that shift in the oral flora will actually predispose patients to opportunistic oral infections, so particularly candidosis, but also other infections. In terms of practical tips that we can advise our patients, or we can help our patients with their dry mouth, I like to break this down into a few different categories. And I should probably say at this stage that all these photos or pictures that I've got, I have no financial conflict of interest here. So I'll put that out there so that it's all clear. But I tend to say to people, if you think about it under these 4 subheadings, so the first is stimulation. So most patients will actually have some residual salivary gland function. And the idea with stimulation is that we're trying to actually make those glands work a little bit harder. The most easy sort of common way to do that is to ask patients to chew sugar-free gum. And it's important that it is sugar-free because we are trying to protect the rest of the dentition. And this will mechanically stimulate the salivary glands. Sometimes we do have options to give patients pilocarpine to pharmacologically stimulate the salivary glands. We talk about replacement of moisture, so asking patients to use frequent sips of water or any of these artificial saliva products. We talk about protection, and we're talking specifically about protection of the remaining dentition, and Matt is going to discuss that in a few minutes. And then there are some things to actually avoid, so particularly anything that will further dehydrate the mouth. So alcohol, caffeine. A lot of patients with their mouth being so sensitive are usually avoiding anything spicy and also abrasive foods. In terms of complications of dryness, I mentioned before that there is an accelerated dental caries process, and we do see what I call atypical caries. So these are caries in weird locations, I guess, very commonly on the cervical sort of surfaces of teeth. And you can see by that radiograph, that OPG, that there is significant deterioration of the dentition. This patient has received radiotherapy, and that process, that caries process, actually is very, very fast. Patients then develop also periodontal disease, and I mentioned before opportunistic oral infections, and in particular candidosis. So we know that Candida albicans is obviously a yeast-like fungus. It does live in the mouth, usually quite happily in harmony with the 50 million other bugs that live in there. And basically with an opportunistic infection, all it takes is a local change or a systemic alteration in that immunosurveillance, and it allows the Candida to overgrow and become and cause an infection. And we do know that oral dryness actually is a very significant risk factor for candidosis, so it provides that opportunity for the Candida to overgrow and become an issue. In terms of clinical presentations, oral candidosis can look like a number of things. The most common thing when we think about Candida is what we commonly attribute to thrush. So we see these white curds that are on the lining of the mouth that can usually be wiped off. and it's usually quite a red raw base underneath. But there are other forms of candidosis. So patients can develop erythematous candidosis, as you can see here. Patients can develop median rhomboid glossitis and a contact lesion on the palate, so a little bald spot in the middle of the tongue and a corresponding erythematous patch on the palate. And some patients can develop angular cheilitis, which is actually quite a common complaint. The last thing I guess I really wanted to emphasize here, particularly for those dental clinicians who are joining us tonight, is the role of mucosal surveillance. So as you will know, many head and neck cancer patients will be followed up by the oncology team for roughly 5 years after they've completed their treatment, and that's the 5-year follow-up plan. Now with the dental team, it really is a lifelong follow-up plan because realistically, these patients require ongoing mucosal surveillance for life. There is also the risk of recurrence and also the risk of second mucosal cancers in the field of radiation. I think our role as dental clinicians is very important. It's really important for us to be looking and ideally detecting any kind of oral pathology very early on, referring to appropriate specialists very early on, and that will then facilitate early intervention and management and essentially will give the patient a much better outcome. And this is my key take-home message. Opportunistic mucosal screening should be undertaken for every patient at every visit. And what I mean by that is that, particularly in the dental setting, you've got a very willing patient who's lying in your dental chair with their mouth open. And that is an opportunity for us to really have a very good look around the mucosal surfaces and screen that mucosa for any changes. Thank you.
Thank you, Sue. That's great. That's lots of pearls in there. To the audience, please do remember that use the Q&A box or the chat box to write down those questions before the end of the talk, so that way it doesn't escape you and we can go through them once we finish. Our next speaker is Associate Professor Matthew Lim, on specifically regarding the dental complications. So please take it away, Matt.
Thanks, Felix, and thanks to all the previous speakers for giving a great introduction to this part of the webinar this evening. But also thank you to the Head and Neck Cancer Society for not forgetting basic dental disease based on all the things that all of our previous speakers have spoken about. The reality is that for most of us here, it's not unexpected or not a new finding that realistically a history of head and neck cancer is almost equivocal with an increased risk of dental disease. And it's because of the reasons that we've talked about. And it's the upsetting of the base, the sort of very simple and fine balance of things within the mouth that sort of upset that process and tip it towards the development of dental decay or periodontal disease. And while that varies between individuals because of the factors that we've all talked about so far, changes to saliva, even to the point of things that Emma's talked about, changes in anatomical aspects and access to the mouth. It is something that all patients are at an increased risk of after they have head and neck cancer. The reality, though, is that it's not a definite that patients need to head down this pathway. And the two key messages that I really would hope people will be able to take away today are that there are two components to oral care that really help us stay in the space of health rather than moving to disease, and that is prevention and early detection and intervention. And I'm hoping to focus on those two particular areas tonight. In the space of prevention, there are some really basic principles that all health professionals can be involved in. And this is not just oral health professionals. This is something that hasn't changed. In addition to basic and regular dental care, the key components really are managing the dry mouth aspects, exactly what Sue Ching was talking about earlier, the hydration, mouth rinses, those types of things to rebalance and replace the saliva. Increased fluoride in the form of toothpaste, like high fluoride toothpaste like Nutrafil 5000, but also encouraging the basics of oral hygiene and oral care. From a dental perspective, it's really looking at how we can make this much more patient-centered. And it's a nuanced approach to looking at the history of dental disease that these patients have, what's going on in their mouth now and where that's likely to lead. And that sort of heads towards that direction of how do we develop an individualized approach to advice and recall for these individual patients. What are sort of the key components of prevention? Without sort of reinventing the wheel and having to retell the story that we already know about oral care, I just wanted to highlight some of the main areas. So the key messages really are around plaque stagnation or fluid stagnation in the mouth. In patients with head and neck cancer, they're not just an indication necessarily of a place where people are missing with brushing, but probably something else that's going on. Either an anatomical change that's meaning that things are staying in that spot, or a change in the saliva that means we need to focus towards those areas. The mechanisms are the same. It's managing the dry mouth, as I said, thinking about things that might rebalance the pH within the mouth, but also really simple things like thinking about getting patients to clean between their teeth before brushing their teeth, as it is, to try and maximize the exposure of these teeth to the fluoride. And that really is the second part of the prevention equation, fluoride. And the two key components are things that people can do at home and things that can be done within the dental clinic. In the home setting, we've talked about some of these things already, the different products that exist. These are high fluoride toothpastes or products that have a calcium phosphate type basis that really have the components within it to try and increase the strength of that tooth structure and make it more resilient to these types of attacks. The key messages are trying to prolong the exposure of these things. So that may be encouraging people to brush their teeth at night, but not to spit out the excess saliva, the excess toothpaste, or smearing a little bit more of these products on their teeth to try and get that increased exposure overnight, or making things like fluoride trays that they can wear overnight to try and increase this exposure and really help strengthen those teeth against those attacks. From the oral health professional side of things, is realistically it's the same type of principles, looking at formulas that are going to increase retention and sustain release around those teeth. So a lot of these products on the screen here are basically the professional versions of that. And really when we're tailoring it to the individuals, it's thinking about how frequent does that application need to be a benefit of the patient. The other aspect of that recall is obviously early detection. As we've talked about, dental disease within these populations is relatively insidious. It happens in areas that we don't suspect, and we really need to have a higher degree of suspicion. So the more frequent recalls and that high degree of, I guess, surveillance of the areas where we wouldn't expect normal sort of dental disease to form are the key components of it. So don't be, the key message here is don't be fooled by the absence of plaque or calculus, because quite often that is the situation of a completely dry mouth and the types of areas or types of mouths in which we're going to get the much more severe disease. When we detect it, what do we do? For the oral health professionals in the room, I don't need to reinvent the wheel and to tell you how to practice. You have all your conventional sources, but this is just a reminder of the things that sometimes don't come to mind straight away. When we're really detecting any form of disease within these mouths, we really want to act early. And it's thinking about what interventions we have that help us make this easier. In the mouths that Emma was talking about, where it's hard to reach, where there's disease everywhere or there's high risk of disease everywhere. And these are some of the tips and tricks that I would have here. The first one is thinking about areas of plaque retention, thinking of preventive things like fissure sealants, but also where there are areas, particularly around the areas that Su Ching was talking about, around the gums, where there may be these sort of retentive areas because of enamel ledges, is thinking about recontouring these as a simple way to try and reduce those plaque traps and increase and tip the balance towards repair. Likewise, please don't forget all the new agents that are out there to help us out with these types of lesions, the things like the silver fluorides that really have an amazing effect in trying to minimize the need for you to go and do the really complex aspects of dentistry that make it really, really challenging to look after head and neck cancer patients and survivorship. So what are the take-home messages from my part of the webinar? Is that I think that we've still got a lot of work to do. While we talk about the pre-treatment dental assessments, optimisation, there's still a lot of advocacy within that space to try and standardise that in the Australian New Zealand setting. Likewise, there's still a lot of advocacy that can happen in the space of trying to promote oral health after head and neck cancer therapies and survivorship and the role of non-oral health professionals within this space. The key messages that I wanted to get across were, one, is that the real aim of this, that all of our dental interventions should be prevention of disease. But where we can't do that is early enough detection to prevent the progression of this disease, to then stop the much more significant impacts that come with head and neck cancer sort of survivorship.
Great. Thank you so much, Matt. That is excellent. There's some really good pearls there, and I think it's going to trigger quite a few discussions. There's some questions starting to come in, and so keep that up. So we've got Dr. Ken Thistlethwaite, who's going to be talking next about one of the treatments that has been used to prevent the incidence of osteoradionecrosis. So Ken, I'm not sure if you're online, but if you are, floor's yours. And if he's not, I'm going to move on to the next speaker, Martin. Oh no, Ken's on. Sorry. There you go. Thank you for that. Excellent.
Sorry about that, Felix. I guess I think I feel like the poor cousin in this discussion, because we were once very much in favour in terms of prevention and treatment of osteoradionecrosis, but now we feel a little bit unwanted. And that's probably fairly reasonable in the setting of where the evidence actually sits at the moment. We lack high level evidence to actually support the use on a routine basis. But on a case-by-case basis for high-risk patients, there probably still is a role for an occasional discussion with the hyperbaric unit about whether we could be of help. It's not that the evidence doesn't show, well, it's not that the evidence shows that hyperbaric oxygen doesn't work, but there are alternative techniques and approaches that have been implemented over the years that actually have removed the need for routine hyperbaric oxygen therapy. Now, if I can just get this working. So I've been asked to give a little bit about the historical perspective and why it was actually relevant, and what's actually happened in terms of that progression. So one of the earliest and most frequent uses of hyperbaric oxygen was for the prevention and treatment of mandibular osteoradionecrosis, and it dates back to the early 70s. A lot of its use was actually in line with the actual incidence of osteoradionecrosis. So some of those dosage studies through the cobalt-60 era and then into the IMRT era are actually very relevant to some of the studies and things that have been done. So we know from the studies performed that basically below 60 Gray, we don't see a significant increase in the incidence of osteoradionecrosis. We know that from 60 to 70 Gray, that can approximate 5%, and that at doses of 70 Gray and above, that can be up to 10% and increasing from there. We know that there are actually approaches to try and decrease that incidence, obviously pre-radiotherapy, dental hygiene, extraction techniques, and the use of IMRT. So this sort of targeted radiation therapy was predicted to actually decrease the incidence. But what we've actually found out that in practical concerns is that the incidence has remained around that sort of 5 to 10% in that therapeutic range. And we think that's because of the changing nature of how we actually use radiation therapy these days. So in the past, we'd used a primary approach with a surgical approach where radiation therapy was used as an adjunct or for salvage. And now we've moved into an era with IMRT where we actually have a primary therapy with chemoradiosensitization. And this has sort of meant that we've actually increased our doses from 50 to 60 Gray to greater than 70 Gray with a curative intent. Now, the initial work with hyperbaric oxygen was actually came out of the US in the early 70s, and the San Antonio Air Force Base there was a major contributor to that work. And initially, hyperbaric oxygen was used with antibiotic therapy, and the reason for it was that it was considered a subset of mandibular osteomyelitis. So in that sort of respect, an oromaxillofacial surgeon by the name of Robert Marks was actually doing some research at the time, and he looked at the etiology and management of osteoradionecrosis as an avascular necrosis. And the reason that he went down this pathway was that he did research actually looking at bone biopsies and had a look for the presence of bacteria, which was absent. He established that 3 H's that we talk about, that hypocellular, hypovascular, and hypoxia, hypoxic tissue, and the idea of an obliterative endarteritis as being the cause for osteoradionecrosis, which we now have evolved into the fibroatrophic sort of theory. But nevertheless, that obliterative endarteritis is still persistent and still seen with most cases of osteoradionecrosis. So with that in mind, he was also at the same time doing research into angiogenesis with hyperbaric oxygen therapy, and he was looking at irradiated models. And he had shown that a therapeutic dose of radiation exposure to the head and neck had reduced that vascular density in that area down to about 20%. He was then able to demonstrate in those animal and human models with transcutaneous oxygen measurements and with actual histological samples that after 20 to 30 daily treatments with hyperbaric oxygen therapy, that vascular density increased to a baseline of about 80%. And it was hoped with that increase to that sort of density that would support tissue healing in that setting. So with that in mind, he gave the bulk of hyperbaric oxygen prior to surgical wounding with the idea that we needed to optimise the surrounding tissues before we actually embarked on a surgical insult. He combined that in a multidisciplinary approach with the excision of all necrotic bone, and he outlined the Marks grading system in 1983, which was a 3-grade system using hyperbaric oxygen as bookends to surgical excision. And it defined the actual severity of the presentation and the management plan. In his grade 3 lesions, which included people who had grade 1 and grade 2 lesions that hadn't progressed, had failed to resolve at that level, and also those more severe presentations, including pathological fracture, fistula presentation, and lytic extension to the inferior margin of the mandible. He proposed using 30 treatments of hyperbaric oxygen therapy with then a segmental excision, followed by fixation with a titanium bone tray used as an external fixator, and then 10 treatments of hyperbaric oxygen after. Patients were then discharged for 3 months, and then he came back and reconstructed the area in a separate operation. His actual technique has evolved over the years, but he published some data in 2017, which I think when you see the word 100%, you always get concerned. But he published data showing that in his treatment of over 35 years of practice with 914 patients, he had 100% resolution in the management of established osteoradionecrosis. Now, it is noted that most of those patients were escalated to grade 3 in terms of how they were managed, and that he also required a cosmetic restoration and restoration of dentition as part of his criteria for success. So this included having restoration of the alveolar height and width and the ability to be able to support a denture or an implant in that area. Once he published that sort of data and he set this management protocol up, that became a standard of care. And throughout the 80s and 90s, that's basically how people managed osteoradionecrosis. But through the early 2000s, there was initially a double-blinded randomized control trial. It was a French trial that was published. And interestingly, although it really wasn't centered around the management of osteoradionecrosis as Marks had actually described, in fact, that study actually looked at whether hyperbaric oxygen could cure osteoradionecrosis by itself without a surgical intervention. It actually got people critically examining the role of hyperbaric oxygen therapy. And in that regard, we started to see people experimenting with different solutions, and we started to see publications of people performing microvascular free flap reconstructions with fibula or forearm grafts without hyperbaric oxygen therapy. And these published results showed very good results for restoration of mandibular continuity. There were concerns about complication rates, about congestion of the flaps, about potential returns to theatre, and the actual ability to be able to establish functional dental rehabilitation in these patients. And that was with respect to actually taking a short segment of bone and being able to shape it so that it actually fitted into the mandible in a reasonable cosmetic sort of finish. And there was concern that the actual effectiveness of that rehab was actually reduced. At the same time, Dr. Sylvie Delaney was working on what has become known as the Pentaclo protocol. So she published a phase 2 trial in 2011. And this actually looked at a medical therapy for treatment of established osteoradionecrosis using pentoxifylline tocopherol clodronate on a Monday to Friday sort of protocol. And then on the weekend, they used a steroid and an antibiotic, ciproxin, to actually for a bit of recovery over the weekend. They published a complete resolution of this group of patients at a median of 9 months exposure, but there was concern over the actual grading of the lesions. In fact, 2/3 of these patients were graded as stage 3 patients, but actually they had less than 1 centimetre of exposed bone. So there was some doubts around that actual grading. And also 11% of their patients actually died from sepsis, which was just something to actually just sort of keep in the back of the mind. But pentaclo has actually progressed from that point in time. It usually involves pentoxifylline and tocopherol. And there's ongoing studies, and there's improvement in those ongoing studies. There does need to be the higher level of studies that we expect of any area, including hyperbaric oxygen therapy. They need to be applied also to the pentaclo regimes, but they're very promising a treatment for the future. In line with his actual success in treating osteoradionecrosis, Marx thought he could use hyperbaric oxygen to prevent it as well. And he published one of the first randomized controlled trials in this area back in 1985. So he theorized that he could use 20 treatments of hyperbaric oxygen therapy. Then he could, he used what was the most likely cause of osteoradionecrosis, being a dental extraction at that point in time. And he used 10 treatments of hyperbaric oxygen after that therapy to actually just support the tissue metabolic demands, to actually see whether we could actually prevent the incidence of or a new incidence of osteoradionecrosis. In this trial, he actually had 74 patients, and he actually had a penicillin arm for prophylaxis and the hyperbaric arm. The penicillin arm actually reduced the incidence to, 29.9%, and the actual hyperbaric arm down to 5.4%. So when he actually published this trial, this also became a standard of care for the prevention of osteoradionecrosis in terms of dental extractions. And again, Marx has published his work, a lifetime's work, in 2017 of 936 patients involving 2019 teeth. And he published an incidence rate of 0.75%, which is, again, quite extraordinary. With the development of these clinical standards, there was, again, a lot of supporting trials, but then we again started to see some dissenting information, and these centred around 4 predominant trials: Suleiman, Mackinnon, Maximu, and Lai. And in these trials, they actually suggested that changing the actual extraction technique and being a little bit more careful on how you actually performed these extractions removed the need for hyperbaric oxygen therapy. This created a lot of discussion, and there was a lot of criticism of these trials as well. And the reasons for the criticism was that they actually used a low-risk group of patients. So these trials all had people with median doses in that 50 to 60 gray range, and they all had greater than 50% of their extractions were actually anterior mandibular teeth and maxillary teeth. So they were a low-risk group of teeth outside of the field of radiation. So that created some nervousness about the conclusions that they were making. And there were a couple of significant review articles that were involved those articles where no new data was presented. So we had then the following decade of concern about whether there was a role for hyperbaric oxygen in the prevention of this disease or not. In 2019, the HOP-ON trial was actually published, and this was designed to replicate Marx's original work. And this actually was a trial which was under-recruited, but they'd always planned that at 6 months, after they got 100 patients, they would have a look at the interim results. Now, they expected in the actual control arm, which was actually chlorhexidine mouthwashes and antibiotics, they expected to see an incidence of around 18%. And what they saw at 6 months was actually an incidence in both arms of around 6%. So what they concluded was that with this low incident rate, there was no need for an intervention, and the trial was halted. Now, the only concerning thing about the HOP-ON trial was that they recruited people with doses of 50 gray and higher, and the mean dose was actually 63 gray. So I don't know if you're just going back to the beginning of just this little bit talk where I was talking about dose incidence studies. And at 63 gray, we would actually expect to get an incident rate of about 5 to 6%. So what this trial actually established really was what had been established in all those previous dose incidence trial, which is actually that if you give a mean of 63 Gray in the treatment of a patient with a head and neck tumour, then the incidence of osteoradionecrosis after dental extractions will be about that 5 to 6% and will not require hyperbaric oxygen therapy. The concern becomes when people get higher doses, when we start to see increasing rates of treatment above 70 Gray, and what that increasing incidence actually means then for treatment with hyperbaric oxygen therapy. It's important to note that the Marks trial, actually the minimum dose in that trial was 68 Gray. So there's quite a difference between the two groups of patients that were recruited. In terms of high-level evidence, though, it's just poor. Since Marks's work in 1983, there's been only one randomised control trial to look at his work, and that was actually published in 2022. And even this trial was under-recruited and they struggled. They actually combined two trials to try and get the numbers. They showed a 20% difference in favour of the involvement of hyperbaric oxygen therapy, but the trial was under-recruited and it was statistically insignificant and subject to type 2 errors, and there's nothing that you can actually draw from that conclusion. And Nain was a ridiculous trial because it didn't even involve a surgical approach, so it doesn't actually support Marks's protocol or not. In terms of the actual prevention, we have Marks's original trial and we have the Shaw trial, and the only differences between those comes down to the patient cohort that was actually recruited. But overall, none of those very short number of randomised control trials support the use of hyperbaric oxygen therapy. So with this lack of high-level evidence, there's been a significant paradigm shift away from hyperbaric oxygen therapy. So on a case-by-case basis, there is still a potential useful role for hyperbaric oxygen therapy. Sorry about that. When considering high-risk patients, with respect to the actual incidence of RRN, patients with 60 Gray or higher may be considered. We've talked about xerostomia and involvement of the salivary gland, and those sort of people are at higher risk of dental caries and things. So they are potential people that could be recommended for treatment. And also those patients that have involvement of their microcirculation, being the smokers and the diabetics. In terms of treatment, we look at those patients that have severe surrounding soft tissue damage that have failed a surgical resolution, and also those other compromised patients. There is an ongoing surgical argument around techniques used in terms of functional dental rehabilitation, but I'll leave that for the surgeons to argue that out. This here is an interesting patient that I treated back in 2004, and it just shows the utility in these high-risk patients. This gentleman was a 63-year-old with a right piriform fossa SCC, and he'd been treated with radiotherapy back in 1992. So he spontaneously developed an orocutaneous fistula 12 years later. So he went through 8 weeks and 3 failed flaps, and then he was referred for a consideration of adjunctive therapy. And here we see his actual treatment pre-hyperbaric oxygen in that top right-hand photo. We see his treatment immediately post the completion of 30 treatments, and we see his results at 6 weeks follow-up, showing complete resolution of the actual fistula. What are some of the other potential areas? Well, I guess any area where there's a surgical insult, there's potential for involvement on a case-by-case basis. One of the areas that has been looked at is laryngeal necrosis, and there's some interest in looking at trials with that. The reason for that is that although the incidence is rare, with an expected incidence of about 1%, when you actually have persistent edema, necrosis, and foul breath persisting for longer than 6 months, the normal management of these sort of patients is a laryngectomy, and these are normally graded according to a score called a Chandler score, grade 1 to 4. Grade 1 and 2 are normally managed conservatively, whereas grade 3 and 4 will often end up with a laryngectomy. So the evidence is poor, but there are actual case series there showing the benefit of hyperbaric oxygen and actually preserving the voice box. And in a series of 44 cases there, just up the top there, which were graded 3 to 4 and should have progressed to laryngectomy, 38 of them retained their voice box and their voice quality. In terms of actual pedicle or free flap repair in a radiated area in the head and neck region, Mark's also published a randomised control report in 2017, which involved 240 patients. And he used his prophylactic treatment arm for ORN for support of this surgery. He managed to show in this cohort of patients that he was able to reduce the risk of wound infection, dehiscence, and delayed wound healing in a statistically significant result. In terms of wound complications post-surgery, one of the feared complications is that rapid breakdown of tissue and that erosion into the major vessels in the neck. And I've unfortunately seen one of those go off in the chamber back in 2002 here in Brisbane, and it's not a very pretty sight. But it has stuck with me, the patients that have actually done well in terms of healing, where it's had these rapid sort of breakdowns and have actually gone on to have good results, and that's been backed up by several case series. There is also support for salvage surgery where primary radiation treatment has actually failed, where we have persisting or recurrent sort of cancer, and we're now using salvage surgery. In this group of patients, the serious complication rate approaches sort of 60%, and hyperbaric oxygen has been used to ameliorate those results. In this sort of study from Feldmeyer, they used 12 treatments and 87.5% of these patients healed well, which is pretty good considering the serious complication rates of 60%. So I guess the take-home message is that the use of hyperbaric oxygen in head and neck surgery is not a routine approach. There is no evidence to support that sort of high-level sort of use. But on a case-by-case basis for high-risk patients, it should be considered. It can be a useful tool, and that's probably the way to think of it, as an extra tool in your armory to prevent and optimize healing. Now, why would you think that that might be useful? Well, there is some good mechanistic advice in terms of evidence, in terms of surgical interventions. We just don't have the clinical data to support it. So hyperbaric oxygen therapy treated at 14 metres will ameliorate the ischemic reperfusion injury for over 24 hours. Very useful in terms of free flaps and things. If we're looking at edema reduction, just even at 10 metres or 2 atmospheres, we get a fluid shift of 8.4%, like an oncotic shift that moves fluid back into the tissue, back into the blood vessels from the tissues. We also know that that increased oxygen that's dissolved in the plasma increases that intercapillary diffusion distance by about 17 times. So in terms of supporting ischemic tissue, you're optimizing that sort of ischemic conundrum. And probably the biggest area has been the research by Steve Tom from the University of Maryland, which is in terms of the actual pathogenesis of soft tissue radiation injury and bony radiation necrosis, the use of hyperbaric oxygen to stimulate increased stem cell mobilization of mesenchymal stem cells and also endothelial stem cells. He's been able to show that one dose of hyperbaric oxygen in an irradiated model doubles the number of circulating stem cells, and that 20 treatments of hyperbaric oxygen in a radiated model increases the number by about 8 times. This effect, he was also able to label those circulating stem cells and show them migrating to the area of ischemic injury. So there is potential uses in all of those things with the head and neck surgery, but that take-home message is on a case-by-case basis for high-risk patients, and the evidence has largely not borne out over time. Okay, thank you. Thanks very much.
Thank you very much, Ken. That was a very excellent, balanced presentation on HBO, and I've certainly learned a lot of that. But I guess, despite all our best efforts, prevention, ORN does still occur, and I think, Martin, this is where sometimes we come in as surgeons, not just on the tumor side, but on the post-treatment side as well. So yeah, please, stage is yours. Let's hear about what happens in this ORN cases.
Thank you, Felix. Hopefully that's visible to everyone.
Yes.
So I'm talking about the surgical management of osteoradionecrosis, and I'm very pleased that we have not yet defined it. So I'll do that quickly. It's exposed bone in a field of radiotherapy greater than a period of 3 months, because delayed wound healing is normal in irradiated patients. There has to be no evidence of recurrence. That's quite important because exposed bone can be due to recurrent malignancy. So a biopsy is pretty important in most of these cases. There's no other cause, for example, medication-related osteonecrosis. And it predominantly affects the mandible in the setting of the head and neck, but it can affect any bone. I've certainly seen it at the maxilla, temporal bone, spinal cord, orbit, and you can get it in the limbs as well, of course. So this is the Head and Neck Society, so we're talking about the head and neck. In the mandible, 90% of cases occur after some form of trauma. Dental extraction is a common one. Dental implant placement, ill-fitting dentures or other trauma are common causes, but a significant number of cases are still spontaneous. So there's no predisposing insult to the bone. And there was a study quite a while ago that basically looked at, we've done a number of studies looking at dental extractions and their impact on the development of osteoradionecrosis, but I think it's quite accurate to say that if you present for treatment for your head and neck cancer and you are a dentulous, your risk of developing ORN is very low, in the order of less than 1%. Whereas if you are dentate, it is much higher. Now, the problem is that rendering someone a dentulous is not good for their quality of life, and it also doesn't give them the risk of an edentulous patient. So the best thing is what all of the speakers tonight have been talking about, which is prevention and management, the careful management of the dentition for prevention of osteoradionecrosis. So what are the risk factors for development? I put these into modifiable, not modifiable, and partially modifiable. Howard gave a good talk about radiotherapy treatment, dose delivery, and I know the radiation oncologists I work with spend a lot of time trying to avoid irradiating the mandible, and their technique for doing that has got much better, and Ken has spoken about the dose dependency, and that is true, and Howard might argue that the radiation dose is not modifiable, but I know they spend a lot of time trying not to irradiate the mandible. You can modify people's nutrition, that is super important, and their smoking status is obviously a modifiable risk factor as well. The use of chemotherapy as an adjunct, difficult to control, and what someone's dental state is when they present for treatment is also not something at this stage we can control, other than by improving the dental health of the general population. Genetics, I think, is probably important. We all know patients who suffer terribly from radiation complications, whereas some patients just seem to breeze through. And I'm sure there's a genetic component to that for those poor individuals. And I don't just mean radiation necrosis, but all the soft tissue necroses that can occur as well. And some of these things are partially modifiable, and that includes by us as head and neck clinicians, particularly post-diagnosis dental care, and that's decisions about treatment of teeth before and after head and neck cancer therapy, surgery and radiotherapy. And we can also be very careful about adjunctive medications, which may increase risks. And I get asked frequently by irradiated head and neck patients whether they should be going on to bisphosphonates or other anti-resorptive medications, and I'm always quite cautious about that, which is another increased risk factor for osteonecrosis of the jaws. Staging, there are as many staging systems for ORN as there are people on this webinar. The Marks one was obviously popular for many years. Ken's gone through that, but it's declined a little as HBO is not used as frequently as it was. And the Natani classification is probably the most common now. That's the original paper if you would like to look it up, but it's pretty simple. Stage 1 is exposed bone confined to the alveolus only. So the alveolus for the non-dental people is the bit of your mandible or maxilla which holds the tooth roots. Stage 2, bone necrosis above the canal. Stage 3, full thickness osteonecrosis, pathologic fracture, or external fistula. Here are a few examples. This is stage 1 on the right of my screen, hopefully the right of your screen, which is alveolar bone. And on the left is stage 2, which is a further exposed bone deeper into the oral cavity, deeper into the mandible in this case. This X-ray is of that same patient who has both grade 2 and grade 3 ORN. Grade 3 ORN on his right-hand side, full thickness involvement, a pathologic fracture. And on the left-hand side, grade 2 ORN, which is involvement of the bone, but limited to that bone above the inferior dental canal. Grade 3, you saw a previous example, but there's another one, a pathologic fracture. And these will often present with external fistulas or draining sinuses in the neck. So what about surgical management? I'm just going to give you, I suppose, what I do. for osteoradionecrosis. And in stage 1, I tend to be actually very conservative. So control risk factors, stop smoking if patients are smokers, increase nutrition, manage their medications. Antiseptic mouth rinses is a standard. Local sequestrectomy, so that means if there's a bit of loose bone, I remove that. And you could see from one of my previous photos that it's quite common to get significant tongue ulceration from sharp bits of alveolar bone. Avoid local flaps or extensive debridement because you can make these cases worse. And I don't usually treat them with antibiotics. I think the only time I prescribe antibiotics for these patients is if they have cellulitis or systemic signs of infection. You can't cure exposed bone with antibiotics, so chronic antibiotics is not, I think, not appropriate. I discuss HBO with them and present evidence to the patient and let them decide, and I discuss the Pentaclo protocol and present evidence to the patient and let them decide. And I often try and prognosticate for them what's going to happen. And again, this is quite anecdotal, but I usually say to people about a third of you will get better, a third of you will stay the same. And if you're asymptomatic, you can actually have exposed bone in your oral cavity for many, many years and not progress. And a third of them will progress to stage 2 and ultimately stage 3. Stage 2, at that stage, I start having a preparatory conversation with the patient about the potential need for a larger procedure eventually. Local debridement, which means more aggressive removal of bone, but I have a fairly low expectation of it healing. Again, antibiotics, but only really if there's cellulitis or systemic signs of infection. And there's been some talk about periosteal free flaps in this cohort of patients. So these are people without pathologic fractures or full thickness involvement of the mandible. And a periosteal free flap is vascularized periosteum with the aim of revascularizing the bone and preventing it going from stage 2 to stage 3. And I'll show you one example of that. The French were really the pioneers for that particular technique, but I know the Lifehouse team have been doing a bit and publishing a little as well. So what about stage 3? And again, I have the same, this is another example on the right-hand side with the classic sign, pathologic fracture, full thickness involvement, external fistula. And for all of these patients, I say you have 3 options. One option is no treatment. You can live with this condition. Most of these people have significant pain and chronic recurrent infection, so that's not a good choice for the majority of patients, but occasionally you'll see people who are pain-free. And really the worst thing that can happen to them is chronic wound dressings, and we'll go through who that might be the right choice for. You can remove the bone without reconstruction, or you can remove the bone and reconstruct it. So no treatment, really appropriate for patients who are asymptomatic, very advanced age or very comorbid. And for those people, it's wound care, basically dressings on the external sinus or fistula, and antibiotics, but only if they have cellulitis or fever. And for those of us who treat medication-related necrosis of the jaws, then that's actually not an uncommon treatment prescription, because many of those patients have widely metastatic cancer. That's the reason they've been on denosumab or Zometa for many, many years. And major surgery in someone with disseminated breast cancer, for example, is not necessarily appropriate. So we frequently prescribe no treatment for those patients, and the same is applicable for ORN occasionally. What about surgical resection without reconstruction? This is an example of a patient who had that. Again, usually only for the elderly or comorbid. And it's only really appropriate for the mandible posterior to about the canine. If you try and do that in the anterior mandible, then people get into a terrible state with lip incompetence and their chin failing. But for the lateral and posterior mandible, and I should have put this patient's post-op photograph in, you can actually tolerate an oral diet, albeit liquid or pureed consistency only. You have chin deviation, obviously, to that side and a malocclusion, but it is very reliable at relieving pain, and the infection will resolve as soon as the dead bone is removed. Surgical resection with reconstruction, that means removal of the osteoradionecrotic bone, replacement with vascularized bone from the same patient. It's a big operation. There is a high risk of complications, but there's also a high success rate. Many of these patients are malnourished. They have poor wound healing, and many of them have also had a history of certainly cigarette abuse, not all of them, but a significant proportion. So those things you have to manage as best you can. And I spend a lot of time looking at radiotherapy treatment diagrams such as this to try and work out how much of the mandible or maxilla you have to remove to try and get into an area of the bone that has had a lower dose of radiation, such that we're confident that our graft will heal to the native mandible. That used to be much easier when people had parallel opposed beams, but it's got more and more complicated as radiotherapy treatment planning has got complicated. So as Howard said earlier, very good communication between surgical teams and radiation oncologists is important for management of osteoradionecrosis, as well as, of course, dental treatment. So these patients, I always say there's a hierarchy of difficulty. All of them who have osteoradionecrosis, of course, have had radiotherapy. It's harder if they've had surgery as well, which some of them have. It's harder if they're smokers. It's harder if they're malnourished, and it's harder if they've got a fistula. So if you get all 5 of those, then you've really got the full house of a difficult day ahead of you. So what are the principles? Can correct the reversible factors, and there's a number of these patients who I put gastrostomy tubes in because they're profoundly malnourished. And I say you can have surgery for your mandible, but you need to gain 10 kilos first. Otherwise, your wounds don't heal. That lady I showed you a photo of earlier, she weighed, I think, 38 kilos when I saw her. And I said, you cannot have surgery at 38 kilos. None of your wounds will heal. So she had a peg, went up to about 45 kilos, had the surgery and a successful outcome. But, you really do need to be very thorough about managing that. Examine neck vasculature. Obviously, you need donor vessels to keep these grafts alive. Discuss donor sites with the patients, review radiotherapy treatment fields, and talk about options. It is a high-risk procedure, but very effective at relief of pain, relief of infection, and we can restore mandibular continuity and provide dental rehabilitation. Here are a few examples. This is, what a pathologic fracture of the mandible looks like before it's removed. In this case, reconstructed with a scapular free flap, and you can see he's got good bony union longer term. This lady had an X-fix on her face. You can imagine that's a pretty distressing way to live your life with a pathological fracture of the anterior mandible. Again, she had a scapular free flap, but you can place implants into those and dentally rehabilitate people. So she's lost her X-fix, gained some teeth, but kept the same earrings. This is the patient I showed you before with grade 3 osteoradionecrosis on the right-hand side and grade 2 on the left. And this is just an example of a periosteal free flap. So for his right-hand side, you can't do a periosteal free flap. That needs to be removed and reconstructed. But he had quite a complicated type of reconstruction with a bit of lateral border of scapula here, some skin which is going in the neck. And this component over here is vascularized periosteum from the tip of his scapula. So the right mandible was reconstructed with the lateral border. This has gone across to the other side of the neck and wrapped around his mandible. And you can see we've managed to not only get full mucosal coverage of that bone, his right side has been fixed as well. And I think I don't have to persuade you that his mandible is quite well corticated there under the periosteal free flap. I personally haven't been game to do that as a prophylactic treatment in patients with stage 2 ORN who aren't having surgery for some other reason, because of a few reasons, but I think there's probably a good theoretical reason why it could work. But it is a big operation for someone who doesn't have a broken jaw or an external sinus. What about dental rehab post-reconstruction? My final slide. The new bone has not had radiotherapy, so there's no risk of ORN. That's quite an important thing to say, that the grafted bone is from elsewhere in the body. It's not been treated with radiotherapy. You do need to confirm that that bone has united to the native mandible or the native maxilla prior to placing dental implants, and that can take quite a long time. So these people in my care will often have CTs, and I won't be considering dental implants until I've seen the bone unite. You don't want to put dental implants into an ununited free flap. And probably the bone is actually the easy part. The bone is healthy, except osseointegrated implants. The integration rate is well over 95%. But the soft tissue can be very challenging despite good bone, and they frequently need vestibuloplasties and grafting, an example of which you can see there to allow for sulcus and prosthetic access. And that's the end. Thank you very much.
Thank you very much, Martin. I think it's an excellent presentation from all the speakers, and thank you very much to you all for sharing all that with us. And I think I must also have to thank the audience. We had 60, over 60 people attending, and still very much the same numbers. So I think it's a testament to the interest in the topic. And I think, I'm very aware of the time. It's getting into the late in the evening, but I do want to have to go through with some questions. So I'm going to get Eric, who's actually collected some of the questions, to start off and discuss that with some of the panelists. And we'll try and go through as many as we can, but we are also aware of the interest of time, and we need to let everyone go and to enjoy the rest of the evening. So Eric, have you got the questions that they've
Yep, thank you very much. I'll go to the question from Eng that really addressed to perhaps Sue and Matthew. What mucositis treatment protocol is recommended by the oral medicine and special needs dentists during the acute phase of treatment? I presume in this setting is chemo or radiations. And perhaps I'll tie in with another questions regarding the role of probiotic. What is it? When do you use it? How long do you use it? And where do you get it?
Matt, do you want to comment first, or shall I go?
You had your microphone on first. You go first, and I'll fill in.
Too keen. So in terms of protocols, look, there are some set protocols which are published. Obviously, I referenced that guideline paper, which has some very good, obviously, guidelines, which you can use. I think what will happen realistically is that it will vary depending on where you work and your experience. There are some, multidisciplinary teams which oral medicine specialists are part of, for instance, and they have their own protocols. In terms of the acute phase, obviously the mouth is very, very inflamed. It's very, very painful. And most of the treatment at that phase is alleviating the discomfort. There's not a lot that you can do once the epithelium has already ulcerated. So there's sort of things that we can do to try and minimize that. But once you've actually developed the mucositis, we're really aiming at pain management and just helping the patient get through that phase. In terms of probiotics, I actually really can't comment on that. I don't know, maybe Matt, you might have some expertise in that area.
I think Howard probably can answer the probiotic question more than I can. But I think the only thing that I wanted to add to your response to is that I think it's all thinking about what is likely to cause the mucositis within the mouth in that setting. And I think it comes back to exactly what Sue was talking about right from the start, which is the dry mouth. For me, the real sort of triggering factor is that we have tissue that's going to take longer to heal. And as a result, and we've got a mouth that's dry where everything's rubbing against each other. And so for me, right from the start, it's trying to get the patients onto a really sort of strict protocol of using mouthwashes sort of routinely, using cryotherapy, anything that's going to keep moisture in their mouth, anything that's going to keep lubrication in their mouth is the sort of the key aspect of trying to prevent getting from that stage, or prevent, I guess, getting the mucositis getting to the point where it is having such an impact because of pain and all the things that Sue was talking about. So I guess that's the only thing that I would have to add to that. But Howard, you talked a little bit about probiotics, I think. Did you want to answer that question?
Yeah, so the randomized trial looked at the Streptococcus salivarius strain as oral probiotics 3 times a day during radiotherapy. In terms of sourcing it, the local chemist just look for that strain. Most patients can get it during their, and I've actually asked patients to source that probiotic during their treatments.
Thank you.
Thank you. I've got a question for Emma, and specifically with regards to trismus exercise and rehabilitation, trying to improve mouth opening. Are there any red flags that the health professionals, whether it be SLPs or sometimes dentists who manage them, or anyone really, like who's there in the community, that should look for to indicate patients that are not progressing with their trismus rehab, or maybe need specialist intervention or medical intervention as well?
Yeah, I mean, I think trismus is always a bit of a team sport. So before we start, and that's where I suppose the assessment part is so important, and making sure that we are not just going gung-ho into a trismus case. We would always speak to whichever oncologist, and not just the surgeons, not just the radiation oncologists, but often we'll double check with both of them. If they've had ORN or any of those sorts of things, then we would usually ask for a scan of some variety to have a look and see whether that's sort of recovered, and we just very much take the surgeon and the our oncology colleagues' guidance about that. I think if we're seeing somebody who you might have got some clearance for starting trismus exercises, you've started some, a pretty rigorous regime. So we usually do a lot of massage, lots of intraoral massage targeted on wherever the scar is, and then we stretch them afterwards to sort of soften and then stretch. If you're doing that and then they're plateauing and there's not a lot of improvement, I think that's a bit of a red flag. I think if they're getting pain, they're getting inflammation, it's pretty normal to be uncomfortable when you're doing the trismus exercises, but they shouldn't be in excruciating pain. They shouldn't be going backwards, unless you've got a really refractory, horrible case of trismus or something along those lines. So I think listening to your patient, having a look at what their trajectory of recovery is. If their patient reported outcomes completely don't look anything like your mouth opening outcomes, I think that's another red flag. And the other red flags would be if they've got anything else like an active cancer process or something like that going on. We wouldn't really want to touch them at that point.
Thank you.
Thanks.
The other question from the floor is regarding xerostomia. Is there any evidence of acupuncture that help for these symptoms? Anyone got any experience?
So I haven't looked at the medical literature around acupuncture and xerostomia, but anecdotally, I do have a number of patients that have gone down that pathway, and many of them have found that it has been quite helpful. So, I certainly don't have an issue with patients exploring that if they should wish to.
And we've got one question, maybe probably can be directed to Martin or even Ken as well. Like there's a patient who sometimes gets extracted. There's a concept of having a 3-month window, and I guess the question is, can you confirm that with what some people used to talk about, 3-month window period post radiation, when it was considered safe to extract teeth? Is that really a case with respect to risk of ORN, or is that something that is more of a myth?
I might start. I think it's probably a myth, to be honest. I don't think we actually know when the right time to do dental extractions is for any patient. One of the problems with extracting them, I understand the need and the desire to extract poor or hopeless teeth before radiotherapy. I think that's reasonable. But when you do that, you have to remember the bone is trying to heal for 3 or 4 months underneath the normally healed mucosa after the tooth extraction, which is basically the immediate time that they're getting radiotherapy. And I think that's why dental extractions don't prevent radiation necrosis. In fact, they might actually exacerbate it. But, having said that, poor or hopeless teeth probably should be removed, but I don't think we know the right time to remove poor or hopeless teeth. And there's certainly never been a randomized controlled trial.
All right.
Thank you. Yeah. This is maybe a bit high tech. Anyone use any device, or can you think of any device that can act as a reservoir for slow release of medication to manage nocturnal xerostomia? If anyone on the panel has tried this, they can talk about the design that work for them. I guess any sort of device or medications or procedure that actually help with specifically nocturnal xerostomia that the panel aware of.
So Eric, I could probably comment a little bit, kind of. So I'm not familiar with any device, and certainly currently don't utilize any in my clinical practice. There are some products that are available, like commercially available products that can be used quite appropriately overnight. So things like xylem melts, I put a little picture of that on my slide. So these little, basically xylitol little pellets, like the shape of a Panadol sort of tablet, that patients just slip underneath their lip, like sitting under their gum, and it sort of slowly dissolves overnight. It gives patients a long-lasting lubrication, and so lots of my patients actually find that quite soothing, particularly at night when we know that physiologically we produce less saliva overnight anyway, and these patients are obviously artificially then dry because we've irradiated them. So that's probably something that a lot of my patients find quite useful in that setting.
Thank you. We might do one more question because it's getting to 8:45. So this is a question related to probably more of a dental matter, like because the audience had asked that if a periodontitis is identified at the pre-treatment dental assessment, would subgingival debridement prior to radiotherapy reduce the risk of ORN in teeth which do not have severe enough perio to warrant extraction, or would the time frame for gingival healing delay the start radiotherapy too much? So I guess it's would you start periodontal treatment and scaling and root planing prophylactically before radiation? Matt, probably.
Yeah, I'm happy to jump in for that one. I don't think there's any disadvantage. I wouldn't worry about the gingival healing time frame impacting on the radiotherapy because I think that's going to have to start when it's going to start. Any interventions that we can have beforehand that are going to encourage better hygiene within the mouth, less inflammation, I think are always going to be beneficial. So I don't think it is necessarily going to reduce the risk of osteoradionecrosis. Because it's not necessarily that perio is going to lead down that pathway anyway. I guess the attendee in their question has already highlighted that it's about assessing the prognosis of the tooth in the long term from that perspective about whether it warrants extraction. But I mean, I think that as much treatment as we can provide prior to therapy is a benefit because we don't know how severe the outcome is going to be after. And there are things like what Emma was talking about in terms of trismus, which make it incredibly difficult for us to do treatment very soon after their radiotherapy quite often. That then means all of this treatment is delayed further and allows sort of disease to sort of start in those particular areas. So I don't think that would be a disadvantage in any way, shape, or form.
Thank you. And I guess on that note, thank you again to all the speakers for sharing your insights and expertise tonight. And I think we've had a really good engagement from the audience. Thank you to Tricia Hogan from GC for sponsoring. It was really, really, really helpful to have that support from industry as well. And thank you all to the audience who actually had maintained all that sort of length of time. I know there was a lot to go through, but I think they're all really pertinent. They're all relevant, and it was a journey from, I guess, the start to the finish of treatment, and then in that survivorship era. So on that note, I'd like to close the webinar and thank again for everyone. We will be sending out a survey through the email to the attendees that I hope that you can all fill in. We do run, ANZ Head Cancer Society runs webinars at least 2 to 3 times a year, and would always be interested to know from members. I know this one was open to ADA members as well. We're very encouraging of that for some topics, to have collaboration with the dental community of future topics that we can present on. So thank you again. Hope everyone has a good night, and take care. Thank you.